We are incredibly privileged today to have as our guest speaker, Dr. Joneigh Khaldun. I'm sure most in this audience are very familiar with Joneigh. I'm going to give a couple of highlights of her bio, but again, a warm welcome, Dr. Khaldun, and thank you so very much for making time for us. Dr. Khaldun is the Chief Medical Executive for the state of Michigan and the Chief Deputy Director for Health. She is a cabinet member of Governor Gretchen Whitmer, who provides advice on public health and aging, Medicaid, behavioral health within the state. It's a big job, and we see her frequently. Notably, this year in 2021, she was also appointed by President Biden to the COVID-19 Health Equity Task Force. She has had many leadership positions, running large municipality health as the chief director or health officer for both Detroit and Baltimore, spearheading things like opioid abuse, hepatitis A outbreaks in Detroit, very important roles. She trained at the University of at George Washington University, where she largely was a director for the Center for Injury Prevention and Control and created and spearheaded the initial fellowship for health policy in the Department of Emergency Medicine there. So Dr. Khaldun has been recognized with numerous 40 under 40 awards. I won't go into all of them here. I will share with you that she is an alum of the University of Michigan undergrad. She received her medical degree at the University of Pennsylvania and her MPH at George Washington University. She is, fortunately for us, an emergency physician by trade, training in SUNY Downstate. Dr. Khaldun, welcome again, and thank you so very much. I'll let you take it from here. And remember, I'll be standing by for you, and our team will be taking questions in the background, and they will be fielded to you at the end of the presentation. So.
Good morning, and thank you so much for that warm introduction. I must say that as of today, I'm actually no longer the Chief Medical Executive and Chief Deputy for Health for the state of Michigan. Certainly bittersweet honor to be in that role, but today I'm no longer. I'm an ER doc, just like all of you. But thank you so much for having me today. I just really love coming. I call it my emergency medicine family when I'm able to speak to you all. So I think my slides should be coming up soon. So my goal today is really to talk to every ER doc, whether you're a PIT doc, whether you're doing research involved in CQI, whether you want to be involved in the community or more broadly involved in policy. I'm hoping to speak to all of you today and really make addressing health disparities and health inequities something that's very practical for emergency medicine physicians. So I don't have any disclosures to make. My statements also do not reflect the official views or opinions of any of my previous or future employers. First slide, I really want to talk a little bit about Detroit, because I really think when you talk about Detroit, and that's quite frankly where my family is, and it really resonates with me personally, you really can get an understanding of what has happened, not just in Detroit, but really across the entire country when it comes to disparities and health inequities. So, the history of Detroit in the 1950s, and you'll see on the slide there, Detroit was actually one of the most populous cities in the entire country. It had over 1.8 million people, and many families, particularly African-American families, migrated from the South to come up north for a better life. There was a booming car industry. My own grandparents used to work in the Chrysler plant. The car plants were located in the city. People's homes were close to them, and people were actually able to make a living by and large and take care of their families. And you can see later on, as decades went on, 60s, 70s, 80s, there was a significant decline in the city's population. And it wasn't only a decline in the city's population, there was a decline specifically in the white population. There was also a significant decline in the wealth of the city's residents. And what you really saw was more and more concentrated poverty, and more concentrated poverty specifically in the African-American community in the city. So on the next slide, so you really can't talk about Detroit without talking about government policies, and really the intentional segregation of many urban cities, including Detroit. So this slide depicts redlining. So what was redlining? Essentially, the Federal Housing Administration in the 1930s redlined specific places, not just in Detroit, in many urban cities across the entire country, where it was thought that specifically based on race, there were some areas of the city where you were basically not allowed to get loans. So if you were Black, you essentially were stuck and unable to move out of the city. You couldn't get a loan, not only just to purchase a home, but basic business loans, loans you may get to improve your home. You weren't able to get those. And literally you can see where it's redlined, where you were unable to get outside of that particular area of the city. However, if you were white, not only were you allowed to buy homes in other places, so I'm thinking of places like Livonia, for example, but you're actually able to be financed with very low payment, low money down, low interest FHA loans. And there were also great jobs. That's about the time when a lot of the car plants in the city of Detroit, they moved to the suburbs. So you had real incentives for people who were not African American to move outside of the city. You could actually build wealth. You didn't have to have a lot of wealth, but you could certainly build wealth by getting a low interest loan. You moved out of the city. That's where the jobs moved as well. And so you really saw, based on housing policy, a real concentration of poverty and lack of wealth. And really, you just wrote in segregation into the actual structure of the city. So on the next slide, you'll see an actual depiction of an excerpt from the Federal Housing Administration actual underwriting manual. These are basically the laws. This is how loans are given. And it documented racist policy. You can see there it describes invasion, specifically saying invasion by racial groups, and essentially, again, writing in segregation right into our housing policy. And again, this was not just in Detroit. This was in many places across the entire country. So the next slide, I find also not surprising, but pretty fascinating, because this slide has a more broad geographical reach than the earlier redlining slide. But what you can see is that it really follows almost exactly the red lines when it comes to housing policy that was put in place back in the 30s. So it's a map of southeastern Michigan, obviously. You can see that there are bright green areas just to the east of the city of Detroit. So Grosse Pointe, quite frankly, where a lot of my physician friends live. You can see places farther to the north and the west of the city where you have a higher life expectancy. So the brighter green means you have a higher life expectancy. Red is lower life expectancy. And so really those same areas where decades ago families were locked out of economic advancement, surprise, surprise, they don't live as long. So the bottom line is, when you concentrate poverty, when you decrease the tax base in a city, when you also subsequently disinvest in a city's children, when you don't allow access to high-paying jobs, there's consequences, and quite frankly, there are deadly consequences. So next slide. So you'll notice that I'm talking about housing policy. I've yet to say anything about an emergency department or a hospital. And so the bottom line is about 80%, I'm sure people have heard this before, but about 80% of someone's health actually has nothing to do with what happens inside of an emergency department, inside of a hospital or a doctor's walls. And it has everything to do with what we've all heard of and learned as far as the social determinants of health. So that's those socioeconomic factors that I talked about. Education, can you get a high-paying job? Do you have social supports and connections? Do you have money? Is your community safe? Do you feel safe walking around your neighborhood? Do you have access to clean air, where you're not worried about your child having asthma, having an asthma attack when they walk outside? Do you have access to clean water? Those are the types of things that really contribute to someone being able to be healthy. And I also want to talk about health behaviors when you're living in poverty. When you're stressed, when you have fewer resources and less access to safe neighborhoods, affordable, healthy food, it's quite frankly more difficult for you to engage in healthy, positive behaviors. And that further perpetuates negative health outcomes. So I'm really trying to set the context here as far as why we have disparities, how policies impact those disparities, and then we'll get into in a little bit how we can have an impact on that. So on the next slide, I want to talk a little bit about definitions, because I think we often just throw out definitions, but if you don't really define what you're describing, it's really hard to address it. So what exactly are health disparities? And I'm not going to read the whole thing there, the definition, but it's a health difference that's closely linked with what I call those social determinants of health. They adversely affect a particular group of people. And it's not just about race and ethnicity. We often talk about that. That's I guess, easy for people to see. But health disparities aren't just about that. It's also about physical ability, social orientation and gender identity, religion, mental health. There's so many other things that actually contribute to and factor into health disparities. So it's really important to be mindful of that as you are practicing emergency medicine or implementing policies and programs in the emergency department or beyond. So then we also have this term called health equity. So what does health equity mean? How does it relate to health disparities? What are these social determinants of health? What does it all mean? So health equity really just means that everybody has a fair and just opportunity to be as healthy as possible. And essentially it recognizes that based on some of the things I talked about earlier, everyone doesn't start on the same playing field. And it's unfortunate, but quite frankly, it's a fact in our country and quite frankly across the globe. Unfortunately, human beings aren't so nice to each other. We've made up differences between each other based on the color of our skin, which we know race is really a social construct. And so now we have inequities. And so if you start at a given point in time and all of the generational disadvantages and ongoing racism or structural inequities that someone may be faced with, if you really look at that person and look at communities, if you really want them to be healthy and have the same chance of being healthy, then you're going to have to put in a little effort, not little effort, quite frankly, it's a lot of effort to undo those structures and those systems that have been put in place, really not just for decades, for centuries. And so next slide, this is not something that I created, but it's something that I love to show. And it really is a depiction of equity. And this really, it can make people uncomfortable because when we're talking about health equity and understanding the root causes of disparities and trying to strive towards health equity, the bottom line is equity does not mean equality. You can see there on the left, if you have someone who is put at a disadvantage, you can see that shorter person on the right. Well, if there's a fence and you give everyone one box to stand on, that person who's shorter, they still can't see over the fence. So you may be high-fiving yourself and thinking like, well, I divided everything evenly. Well, you're not factoring in the context of where people have been, what they're experiencing when you're addressing their health and their ability to be healthier. And so you really have to think about equity. Some people are going to need more. They're going to need more resources. And that's really what you have to address if you're gonna improve health disparities. And then I love the depiction on the right where it talks about liberation. Quite frankly, why do we need the fence anyway? Oftentimes we put these structures in place to really promote power and structure that have been in place for decades, but oftentimes you don't even need the fence at all. And equity and liberation on the right, everyone really wins. If you really break down the barriers and the systems, you don't have to take away from anyone else. We want everyone to be healthy. It's not about taking away from someone else to give someone else more. Everyone, including those who are wealthy or who come from privilege, we want those people. I want those people to be just as healthy as everyone else. I just recognize that because of historical context, it's going to take a different approach to make sure everyone has the same opportunity. So what are the key points on the next slide about equity? Again, it's very uncomfortable, but equity does not mean equal. It recognizes, again, the inherent discrimination and challenges that marginalized people in this country, again, not only just because of race, but other things as well, things that they face. And it also works to make sure that everyone achieves optimal health, and you have to really put in the resources and be intentional if you're going to do that. So the next slide is one of my favorite quotes from Dr. Martin Luther King. And really, of all the forms of inequality, injustice in health is the most shocking and inhuman, quite frankly, because it results in death. And I'll tell you that what has occurred over the past 19 months across the globe, and of course across the country and here in Michigan, is just absolutely horrifying. The fact that COVID-19 has disproportionately disparaged and ravaged communities of color, not just communities of color, but also people who are disabled, people who have underlying medical conditions. The fact that that has happened, quite frankly, it's not surprising at all, because those very structures and systems that I talked about, of course, if a pandemic hits, it's going to hit people who have been marginalized harder. And unfortunately, the bottom line is there's more people disproportionately who are dead, who are people of color, because of those historical structures. So again, all that sounds negative, but I think it's really important to point out that we have to understand our history and understand the reasons for people being where they are if we're going to make improvements. And I'm quite optimistic that you actually can make improvements in health disparities and address health inequities. So the next slide is quite glaring. This is 2020. The COVID-19 pandemic when it comes to case rates specifically. Now, of course, all of us know very well that we did not have sufficient testing, particularly early on in the pandemic. But Michigan was one of the hardest hit states early on in the pandemic. Again, if you think about the city of Detroit and southeastern Michigan and all of the inequities that were concentrated there, you all know that southeast Michigan, Detroit was hardest hit by COVID-19 in the beginning, and particularly African Americans had a much higher case rate and unfortunately death rate than all other racial groups here in the state. And then what you can see, which I'll talk about in a moment, is that we were actually able to essentially eliminate, which is interesting, the black-white disparity when it came to cases and deaths last summer. Now, I'll tell you, even when I would talk to the governor and my team about how we were able to successfully do this, and we were very intentional about it, I always knew that it would be very fragile, and I was not really excited about high-fiving and telling people that we had successfully eliminated health disparities, because I know that the structural inequities and poverty and all the things that cause the disparity in the first place, there's no way that that would last very long, but we did see some success. We do currently still have a black-white disparity when it comes to COVID-19 cases and deaths, but that gap has significantly closed, and that's because we really took intentional action, which I'll talk about. So why were there any COVID-19 health inequities? And this is on the next slide, I hope. So again, it's uncomfortable to say, but historically, it's really not about the color of your skin. There's nothing about having darker toned skin that means that you're more susceptible to COVID-19 for some reason. So absolutely not. It's about quality education. What type of job do you have or do you not have? Are you a frontline worker? Are you able to work from home? Do you have your own private car where you can drive around and go where you need to go? You don't need to take public transportation. Those things are really, really important. Do you have stable housing? Do you have the supports in place to be able to? I mean, the CDC initial guidance on quarantine and isolation was use a separate bathroom, isolate from other people in your home. Well, who has, outside of us doctors and some other folks, who are well off, quite frankly, compared to most other people, who has multiple bathrooms in their home where if they get COVID-19, they can just nicely isolate? So it really wasn't even practical. And the things that we were telling people to do to protect themselves, a lot of folks simply were not set up to even be able to do. And I'd also add that all those things I talked about and the decreased life expectancy based on where you live, all those things also contribute to chronic stress. They contribute to chronic trauma. It leads to less healthy behaviors and those underlying medical conditions. So that's the health disparity. And we all know that if you're obese, high blood pressure, underlying medical conditions, those are things that actually make you more likely to get severe COVID and lose your life. So again, it's just this cycle of perpetual inequities that really just sets you up to be more likely to die during a pandemic. So I want to talk a little more about what went wrong with COVID-19. And this is not about Michigan, this is really just about the country. So I already talked a bit about social determinants of health and people not being able to protect themselves and stay home, being frontline workers. But let's also talk a little bit about our early vaccination efforts. So you and I mean, I got my vaccine the first week they were available because I'm an emergency medicine physician, and it was determined that I deserved a vaccine earlier. Now, I'm not disagreeing with that. Obviously, if we're intubating COVID-19 patients, we should be vaccinated. So I don't disagree with that. But I also had pretty easy access to a vaccine. I also have a car. My home, we have a couple of cars. It was easy. If I couldn't go to Henry Ford to get my vaccination, I could easily just drive wherever I wanted to and get my vaccine. So just by design in our country, when we started with this massive vaccination push, even when we tried to put vaccines in communities where people perhaps did not have access to transportation, or they were essential workers as they became eligible as time went on, those people actually had less access. Mass vaccination clinics. If you don't have a car, you can't travel across the state, which I know people were traveling across state lines and people were mad at me and said they went to Ohio because I was taking too long. But you know, if you couldn't just do that, then you couldn't get access to a vaccine. So our vaccination efforts by design, quite frankly, perpetuated disparities. If you think about access to testing, very early on, there were limited tests. I do think that bias came into play. I mean, we know in those really early rough days, really your resident, you as a staff attendant, you could determine who could get a test. We were telling people, oh, you're fine, you probably have COVID, just go home. I know that's what people were doing. And there are people who, quite frankly, probably in the very beginning did not get a test, or maybe they should have been brought into the hospital for observation because they were at high risk of decompensating. And we sent them home and we didn't get them a test, and unfortunately people died. So again, this is not about anyone intentionally wanting to kill people. I do not think that anyone in emergency medicine goes into their shift wanting to perpetuate structural inequities or wanting to have implicit bias, but I think it's just a fact of the system, how we were trained, how the public health system was just, quite frankly, ill prepared to be able to fight a pandemic, and it set us up for where we ended up. I'd also say limited access to monoclonal antibodies. We still have disparities when it comes to who's eligible for monoclonal antibodies for COVID-19 if they're positive, and who's actually getting them across the state. And so again, these are just inequities and disparities that are perpetuated in the context of a pandemic. So next slide. So what did we do? So I'm very proud. I'd say first and foremost, you really have to have strong leadership. And I would say that we have. Michigan, still to this day, we have one of the lowest case rates, case numbers when it comes to COVID-19. And while we did in the spring of this year have a surge, we still, by and large, have lower case rates than much of the country. And I think that's because we were very intentional. As I mentioned earlier, we did very specific things to address health disparities. So what was that? Our governor, I talked to her, she said, Joneigh, what can we do? Well, one, you have to name the problem. And I don't think that, I never want to think that declarations and statements are actually policy, but just the governor standing up and declaring that racism specifically is a public health crisis, I think that really meant a lot. We followed up with the announcement of Racial Disparities Task Force, so bringing in community members to identify and address the problem. We also really put targeted resources where the disparities were. So we actually put millions of dollars into, again, in the very beginning, the pandemic was focused really in the Detroit metro area. So we put a lot of dollars into a multimedia campaign focused there. Sometimes it was me speaking, but it didn't always have to be Dr. J, who was on camera. We really had trusted community members in the community being able to bring the message forward. At that time, it was really about just how to be safe and wearing a mask. We actually distributed over 6 million free masks across the entire state. And then, this is important, we use data. We actually use something called the social Vulnerability Index, which is a tool that's put out by the CDC, where you can track not just by race and ethnicity, but by language, by number of people in home, by age of people in home. It's an index that essentially looks at how vulnerable socially someone may be. And so we actually looked at that and placed testing sites in those areas that had the highest social vulnerability index to expand testing. We partnered with community-based organizations. We expanded food, WIC benefits. We had an eviction moratorium. And importantly, something I didn't talk about in the last slide, we mandated race and ethnicity reporting. I know many of you are data folks, you're quality improvement folks. If you don't have data, there's absolutely no way you can identify a problem or be able to address it. So we were actually one of the first states to mandate the reporting, but also to analyze and actually publish our COVID case and death data by race and ethnicity. I think there are still there's still limitations. There's still too many missing data that we have, but it was really an important step. And I think it's really important that we strengthen our data infrastructure if we're going to be able to address any health crisis and address health inequities. And then we also mandated implicit bias training. So for all state employees, that was required. And now we actually will have implicit bias training that's part of your CME, our license renewal requirement. I think that goes into place in next year. So really intentional, as you saw on a previous slide, we were able to decrease those disparities when it came to COVID-19. So next slide. Okay, I talked about COVID. I talked about the reasons for disparities and inequities. So you may be thinking, okay, so what? What does this have to do with an emergency medicine physician? When I go into work every day, I do my best, I practice good medicine. I know all of you do, but is there anything you can actually do to address these disparities that I know that none of you personally have caused, but how can you be a part of the solution and promote health equity? And so I wanted to just, and I'm not going to go into detail, but there are many studies and there's much data out there about racial disparities and inequities that exist in an emergency department. And again, I don't believe they are intentional. They are things that, because we are all human beings, we come into our lives and our jobs and where we are with our own biases. And it impacts how people receive care. So whether it's pain management, whether it's how we address trauma patients, whether it's the use of restraints, whether it's someone getting to a cardiac catheterization, there are many studies that do actually suggest that there is bias in the emergency department, in the broader healthcare system, and that we can actually do something about it. So I like to always keep things simple. So on the next slide, you'll see kind of my, how I think about how an emergency medicine physician can get involved. So every doctor, you don't have to want to be the chief medical executive of a state. You don't have to be Superman or Superwoman. You don't have to run for office, but you can if you want to, that'd be great. But there are really things that can be done if you're mindful and intentional at the bedside, operationally in the emergency department, in your role as a clinician or educator or researcher, and at the broader policy level to really advocate for your patients and improve their health. So next slide, I'll go through some of these. This kind of goes in more detail about what emergency medicine physicians can do. So let's just talk about, you just want to go work your shifts and come home. Fair enough. There's nothing wrong with that. Being an ER doctor is very noble, and that is sufficient. But I'd say one thing you can do at the bedside is be aware of and challenge your own biases. I think that's one of the first steps that people can do. That's why I advise the governor that implicit bias training would be something that would be a tangible action we could all work on for every provider in the state. And, I'll say, I have my own anecdotal experiences, for example, in medical school, where I'd be in rounds and I'd hear my attendings talk about how they didn't know if someone was really unhealthy, or they couldn't tell if someone had a rash because they had darker skin, or having an African-American patient whose hair was falling out and saying, oh, well, I think that's normal because they're African-American, so their hair should be falling out. I've had interactions where it was during the month of Ramadan, and a woman had come in with abdominal pain, and I literally had a nurse tell me, "Oh, well, it's Ramadan, so we don't really have to worry about it. I'm not going to check her vitals. She's just fasting, so we should send her home. There's nothing to do." Well, why would we not treat someone? Why can we not identify a rash? Why can we not identify that it's unhealthy for someone's hair to fall out, or that someone could be having cholecystitis? We really have to think about and check our biases and our assumptions about the people that we're treating. And again, it's just human nature. When people are not like us, or we perceive them to be not unlike us, then our biases absolutely do factor into how we think about their care. And that can have an impact on us being able to diagnose. It can have an impact on our, quite frankly, our attitude when we're interacting with a patient, and how that patient perceives the healthcare system. If someone comes in and they think they're being disrespected, or they're not being listened to, or they're being disregarded, they're less likely to want to engage in care. They're more likely to leave against medical advice. And so those are all the things that we just have to be mindful of as practicing clinicians. Another important thing is to just assess your patient's social determinant of health kind of needs. And I'd say that you're not kind of anointed with a social determinant. We all have social determinants of health. Those are the things that determine how likely you are to be healthy. So it's not something that someone's kind of pinned with. They're just things. If someone can't get to their doctor's appointment, if they just lost their job, or they just lost their insurance, you may not be able to fix the system. I'm not asking anyone to be a social worker in the emergency department if you're the physician, but can you at least ask the question and ask, do they need any help with getting somewhere? And don't make assumptions. Don't make assumptions, quite frankly, if someone is a person of color, that they're poor. I think that's important as well. Don't assume that if someone is white, that they don't have access issues. We really have to see the patient in front of us and at least ask the question. I would say another thing, and my residents who work with me, I feel like they're always laughing because I always bring public health into my shift. But you got to be at least a little familiar with some of the local resources that are available to your patients. I know I often, because I would be in the health department kind of running programs there, I would sometimes just bring some flyers in. Bring some flyers into the emergency department and just say, hey, there's a clinic over there on the corner. You don't need to come back to the ED for this particular thing. You can actually go to a clinic, or there's resources here. Those are just very simple things that can be done. If you're in a leadership medical director role in an emergency department, you can do that too. Keep those resources updated. Don't necessarily wait till someone's homeless or they have a placement issue to do any type of social needs assessment. And I'm not asking for a robust assessment and filling out a form. It's just like, hey, you just lost your job. You can at least ask the question, give them a flyer, and just try a little bit as you're discharging them. And I'd also say, know your emergency department's referral programs and use them. I was just working in the emergency department this past weekend, and one of my patients was positive for COVID. They weren't that sick. And I said, oh, well, what about, can we connect them to monoclonal antibodies as an outpatient? The resident said, oh, I forgot about that. Oh yeah, I guess maybe we could. I get that in the flow of patient care, sometimes it can be challenging, but at least know what exists in your emergency department, but also in the community. So if you have more broad emergency department kind of operational authority, there's also things you can do. That's that second column there. You can promote diversity in hiring. You can promote mentorship and promotions to really increase the diversity of who's working in your emergency department or in your hospital. It's pretty well established that when you have a diverse workforce, when your patients see themselves in the people who are treating them, that you tend to have improved outcomes and better experiences when it comes to engaging with the healthcare system. Now, don't get me wrong, that does not mean that you need to be African American to provide high quality, unbiased care to someone. Absolutely not. But it does help to have improved diversity in your emergency department. And I'm a big fan of maximizing public health interventions in the emergency department. I used to wave this flag before the COVID pandemic. And I think that now we all really understand you cannot separate public health and public health crises from an emergency department. And it actually benefits us and us being able to actually execute and practice and keep our emergency departments functioning when we pay attention to what's going on in the emergency department. So whether it's hepatitis A, testing and vaccination, something I pushed when I was Detroit's health director. We were in the middle of the largest hepatitis A outbreak in modern history, whether it's flu vaccinations, COVID vaccines. I know that it can be challenging and it's something new. It's something that has to be thought out when it comes to operations. I totally recognize it's a challenge when you got 50 people in the waiting room, but let's just be honest, when people are waiting around for a long time, there are often ways that we can integrate very simple, I'll call them simple, obviously I'm biased, public health interventions that can actually have an impact in the broader community if we just kind of take some time to think them through. I'd also say when you're looking at your metrics for your emergency department operations, take a little more time and look at your metrics and at least try to break them down across race and ethnicity. If you're not measuring it, if you're not identifying it, you're never going to be able to fix it. So I would challenge people as you're working on your QI projects to actually look at your data and try to see if there are any disparities that you may even be exacerbating by your projects. In the community, it's really important. I think that hospitals and communities should be connected. I think it's a shame that many hospitals had no idea who their local public health officer was until the pandemic hit. Well, you probably knew me when I was in Detroit because I was just a busybody and knocking on everyone's door. But oftentimes people don't know who their local government officials are. And that's really a loss. It's really unfortunate because those relationships are really critical. Oftentimes local health departments don't have staff, but they do have certain authority and they do have the ability to partner with you to actually be able to advance some of the work that you may want to do in your emergency department. I'd also say from a research perspective, implement community-based participatory research wherever you can. And so this is just very simply engaging with community members. You don't have to have a PhD or master's degree to be able to participate in research. Don't just go research in a community and not really engage them in the entire research process, designing a study, being an author in the study, engaging the community as far as the results and what should be done next to actually address whatever the finding was. That real spirit of CVPR is really important. I think would go a long way. And then also, finally, this is where I've spent a lot of my past, I guess, 7 years or so, but advocate for policies that best serve your patients. You know more than anybody what your patients are experiencing and what you see in the emergency department. Serve on important committees that drive policy and programming. And I'm not going to be doing this, but people can certainly run for office because what's better than having ER docs be in charge? So on the next slide. This is a study that I wanted to, not really a study, it's really a review of a QI process that was put in place in a hospital in Wisconsin. And I really thought it was interesting and really drove home the point of how you actually can implement public health interventions in an emergency department. So this was an interdisciplinary team that was putting together a QI process because they wanted to increase their pediatric flu vaccinations in the emergency department. We all know how important flu vaccines are. Unfortunately, we know that oftentimes most people actually don't get a flu shot every year. So this team was trying to do something about it. So they put in place a plan, do, study, act, cycle, process that works. So they actually did 5 things. They mandated vaccine screening by their nurses. They created a nursing administration protocol for the vaccine. They put in a lot of effort into educating providers, nurses, and families. They involved their pharmacy team as well and created a pharmacy workflow. And there was weekly staff feedback as far as what staff were experiencing, what they were concerned about through that process, things like vaccine wastage and the time from a nurse saying someone needed a vaccine to a provider actually talking to the patient and saying, yes, they should get a vaccine. So they worked through all of those things and they had pretty positive results on the next slide. So their screening actually went from 0, they weren't asking anyone in the beginning, to about 90%. 90% of their patients are being screened for flu vaccination eligibility. And they actually were able to improve their vaccination rates by about 8.5% in eligible children. About 80% of the vaccines that were given were actually children who had Medicaid. And what's really important and interesting about this, there was no significant increase in the ED length of stay for those patients. And they actually added, it's okay to make some money. They actually added a little bit of money, a couple dollars, $22,000 in hospital revenue over the span of 6 months. So I think my point here and why I put this in here is I know that often public health interventions in the emergency department, when you're just trying to kind of keep patients flowing, can seem overwhelming. But I really think, and I hope that this pandemic has taught us that oftentimes the emergency department is the only place where particularly people who are from marginalized groups are going to seek care for various reasons. Transportation, they lost their health insurance, whatever it may be. We have to really see the emergency department as a golden opportunity to do the best thing for people and to improve their care and, quite frankly, to protect the public's health. And I think, again, this is something that I hope everyone has learned from the COVID pandemic. I know it's not easy, but I think with intentionality, it can actually be done. So next slide. If you really want to be kind of a champion for public health from an emergency department perspective, again, know your local public health leaders. They would love to meet with you, understand what you're doing, and see how they can collaborate. Know your legislators. Don't just wait till you think that your grant may be cut from whatever grant or project you may have. Know your legislators. Develop relationships with policymakers. Go up to MDHHS and have relationships with people before you actually need something. Help them see you as just a partner in general in improving the health of the community. It's really important. So today is a new fiscal year. It's really important that you understand how the budget process works in the state, particularly when you're seeking to get funding or you're worried about when your funding may start or end. I know I heard when I was, as of last week, when I was in the state, people were very concerned and said, oh, my funding's running out. Well, everyone's funding. My own salary was running out because there was no budget approved. So I think just understanding the concepts and how budgets work is also really important and can be used to your advantage. When you're advocating with policymakers, know your key statistics. Be very succinct. Have a specific ask and know the projected impact of your ask. This is something when I used to teach in DC, health policy. It's really important that you understand how to advocate. Policymakers don't want to be presented a bunch of 30-page papers and research articles. They want to know what's the impact, how much is it going to cost, how am I going to get it done? And that's really important when you're advocating with people and with legislators that you really have a specific ask. And then also, please realize, I mean, having worked in Baltimore, Detroit at the state level, public health staff, you will not find a more committed staff, but they're also a little bit tired right now, and they're also underfunded and understaffed. So really just keep that in mind when you're seeking to engage, when you want to work on projects with them. They can actually use your support, and try not to yell at them too much if you get frustrated, because they are certainly working hard. So in summary, thanks, my last slide, you know, I wanted to talk about place and space and racism and the structural barriers that are really the drivers of health inequities and cause the health disparities. But I think I'm optimistic because those disparities and inequities, they're not inevitable, and with intentionality, which we did with the COVID-19 crisis response in the state, you can actually eliminate and decrease health disparities. It's not something that has to exist. And I think, of course, I'm biased, but ER docs, we have grit. We can see the big picture, the forest. We can also see the trees, and we can float between the two all the time. I think that we are just uniquely suited to impact public health and health inequities on multiple levels. So I would just ask all of you to think big, think about very specific and simple things that you can do And also make sure that you know who's in government and who your legislators are, and really be an advocate for your patients. So with that, I will stop and see if there's any questions. Thank you for having me.
Thanks, Dr. Khaldun. That was tremendous. And we really want to thank you again. It's just a superb discussion. I'm going to let Katie Garnachia ask a few questions here. I know they've been coming in.
So our first question, what do you feel are the greatest barriers to delivering equitable care in the ED that could be prioritized for action?
Yeah, I think the greatest barriers in the emergency department, again, I'm still working. I know I was working, and I don't know if my medical director is on this call. I know he's involved with Medic, but I know that we're short-staffed. We don't have nurses to be able to even open up parts of an emergency department. So I get how challenging it can be. But I also think that sometimes we make things more difficult and complex than they need to be. And I'll give an example of COVID vaccinations in the emergency department. I was talking to the president of MSAP and, trying, like I usually do, I've been doing this for years. I'm always trying to bring public health interventions into the emergency department. But some of the feedback that I hear from various emergency department leaders is that, oh, well, we asked the patient and they didn't want it. Or it takes too much work, it takes too much time out. Which, again, I'm practicing, I get it, but, at this point, and this has been the truth for at least the past 3, 4, 5 months, one vaccine in an arm is actually, that's pretty good. If you can do even a few a day in the emergency department, if you can, spread that out across every ER in the state, that's actually significant progress. And so I think that the fact that you don't get 100% acceptance rate, that being used as a reason for not wanting to implement a process, I think that's, I would encourage us to push a little more and think about the yes, instead of always thinking about, oh, there's a barrier, or it's not perfect, and so therefore it's going to be a no. Emergency departments are where the most vulnerable are going to go. That's not going to stop. So we might as well embrace it and think about how we can improve the lives of our community. Quite frankly, again, we are helping ourselves even if we can address something like a pandemic.
Thanks. Great advice.
I do have one more question. What data are needed to better understand the problems of equity in the ED so that interventions may be planned? Yeah,
that's a really important question. I mean, I struggled in the beginning, even to get the little race and ethnicity data that we did about COVID-19. I think the problem is really there's not a data infrastructure. So you may recall those lab forms you had to fill out to get a COVID test in the beginning. So those were literally facts to us. There's no system in place for us to be able to understand race and ethnicity, let alone, I was asking my team, can we get disability status? Can we get veteran status? Can we understand what language someone speaks? We really need to understand and get that robust set of data. And then importantly, data has to be disaggregated. If we don't disaggregate the data and we put everybody, every group into one particular category, we're not going to understand how different communities are being impacted by whatever the health issue is. And therefore, we're not going to be able to be specific with our interventions. So I think broad, robust data, asking the question, not just race and ethnicity, and are you black, white, or other, or whatever it is. There's only 4 categories of race that are on most surveys. Go a little deeper, think about disability status, and then when you're trying to understand what's happening, you really got to disaggregate the data, which is really, really important, something I've been advocating for on a national level as well.
Thank you. I have one follow-up question to that, Dr. Khaldun. So we understand the data problems, and I think Keith Coker is going to talk a bit more with our fellows this summer. But I'm sorry, their work this past summer. But from your standpoint, are there models of people who are emergency department, groups within states that are doing this better than Michigan, or who you would say are are leaders in this, collection of trying to integrate social determinants of health into data capture. Does anyone stand out?
There is, there's folks on the East Coast, I'm like forgetting now, but there are folks who are, was it Boston University? There's some folks at Yale. And but I also think there's some of this work going on in Michigan. I think that folks who are really trying to understand the social needs of their patients and then targeting interventions specifically to what their patients need is really important. I'd also say we love talking about screening for social determinants of health. It's like, why get a white count if you're not going to do something about it, right? Like, don't order a test if it's not going to change your management. Don't just screen for something if you can't do anything about it, just so you can get some data. I think that's really, really important. But I think, to be honest with you, these data issues, they are well beyond an emergency department or one single health system. It comes from CMS, it comes from the federal government and requirements. Health systems are not incentivized to update their electronic medical records so that they can actually track easily these data in their EMRs. Our public health systems, I mean, half of them were using fax machines when the pandemic started. There's no way to actually aggregate the data and then disaggregate it later. I know there's been some complaints even across the country about health departments no longer posting COVID data on a daily basis. Well, that's not about health departments being lazy, if you will. Literally, you have like one person who behind the scenes every day, including Saturday and Sunday for an entire year, had to pull the data, do all the technical stuff that I don't know how to do behind the scenes, and then put it together into a file that's posted on our website. And so literally that is how data is being compiled to try to understand the COVID-19 response. And until as a country, we invest in data system infrastructure with mandates and incentives, and quite frankly, we have to penalize systems if they're not doing it and tracking data and reporting it in a timely way. I think we're never gonna get anywhere. So that was a long answer, but I think it's beyond just what one single emergency department can do.
Thank you for that. Thank you very, very much. I know it's woefully inadequate, but we wanted to, say thank you in a warm way for speaking today. We know you're a very busy person. I know you've, stepped away from the government role, but we wanted to make sure that everybody here conveyed their deep thanks for spending time with us and informing us. So I want to make sure that you see this, and oops, I have it backwards. There we go. So that we'll put this on your book stand, and I was here in Medic on October 1st. And I hope you have a wonderful day, and thanks so much. If there are follow-up questions, Dr. Khaldun will be sure to send them your way. Thanks again.
Thank you.